Dear friends, I am Dr. Deepak Chaudhary, Principal Director and Head, Department of Arthroscopy and Sports Medicine at BLK Max Super Speciality Hospital. Today I will be speaking on posterolateral corner injuries of the knee. Is it still a dark corner? Posterolateral corner injuries a few years back was considered to be dark corner because we were not aware of the anatomy, the biomechanics was not very clear, and the surgical techniques were also non-anatomical, resulting in poor clinical outcomes. But now we have got much better understanding of the anatomy of the PLC. So why was it considered to be the dark side of the knee? Because there were no good anatomical studies to show what are the ligaments present on that side of the knee joint. The diagnosis was often missed both clinically and on MRI. The failure to address the lateral side of the knee was a frequent cause of failure of the cruciate ligaments. Most of the surgeries were non-anatomical and the patients were post-op, they were put in a cast resulting in a stiff knee. The rehab protocols were not properly defined, and all this resulted in poor outcome and a high rate of recurrence. The PLC injuries, isolated injuries, are very uncommon. They are usually associated with either the ACL or the PCL injuries. They are frequently missed, and if you don't address them during the ACL PCL reconstruction, they can put a lot of stress on the reconstructed ACL PCL, resulting in their failure. And if they are not properly surgically treated, it leads to a varus and rotational instability. Many of these injuries, they are associated with peroneal nerve injuries as well. So repair is best done when the injury is less than 3 weeks, and after the 4 to 6 weeks it is usually the reconstruction. There are various reconstruction techniques, anatomical versus isometric. Of these, the anatomical ones are the most successful since they restore the anatomy and the biomechanics. So it is very important to understand the anatomy of the posterolateral corner of the knee. There are certain static stabilizers which are very important. This is the fibular collateral ligament, the popliteus tendon, and the popliteofibular ligaments. There are other lateral knee structures as well which need attention. These are the posterolateral capsule, the meniscofemoral ligaments, the fabulofibular ligaments, the biceps femoris, long head, and the IT band. Among the most important stabilizing structures on the lateral side, we have the fibular collateral ligaments. On the femoral side, it is attached just proximal and posterior to the lateral epicondyle, and on the fibular, it has got attachment midway along the fibular head. Again, popliteus, another very important static stabilizer. Its attachment on the femur is it attaches on the anterior fifth of the popliteal sulcus on the femoral side. The average distance between the fibular collateral and the popliteus on the femur is about 18 to 18.5 millimeters, and while reconstructing the tunnels on the femoral side, this distance must be observed and validated. Another very important ligament is the popliteofibular ligament, which originates at the musculotendinous junction of the popliteus, and it is considered to be a static stabilizer, resulting in stability in external rotation and varus stability. The prime function of the LCL and PLC is to resist varus stresses when an adducting force is applied on the knee. The primary restraint to varus is lateral collateral ligament, and the primary restraint to posterior subluxation of the lateral tibial plateau with external rotation is the PLC, that is the PLC and the popliteus tendon. So the various mechanism of injury, the direct varus stress, hyperextension or twisting of the knee, these are some of the very common mechanisms resulting in injury to the PLC. It is very common in football, soccer, basketball, and rugby. It can often occur in road traffic accidents in association with the other ligaments like the ACL or the PCL. Again, it is very important that every case of ACL and PCL must be examined for PLC injury. And for that, in a chronic case, very important is to observe the gait. There is often a posterolateral thrust while walking. Again, there could be involvement of the peroneal nerve, and this must be documented. The varus stress test is the most important test to determine the amount of opening on the lateral side, to quantify it, and to that serves as a baseline for reconstructive procedures during follow-up also. The various other tests, the reverse pivot shift test, the recurvatum test are also helpful in diagnosis, and also the dial test, which at 30 degrees denotes a PLC injury, and if it is positive at 90 degrees, it denotes a PLC as well as a PCL injury. So as I said, varus stress testing is very important, and if the side to side opening is more than 2.7 millimeter, it indicates an isolated tear of the fibular collateral ligament. However, if this distance is more than 4 millimeter, this means a complete tear of all the not only the fibular collateral but also the popliteofibular and the popliteus injury to all the three major structures. So the diagnosis is clinical. Stress X-ray are the most important thing. MRI in acute stage helps in diagnosis, but in chronic cases, sometimes the ligaments appear as normal, and one cannot make out on MRI in some cases, in chronic cases. And again, arthroscopy also helps in confirming the diagnosis if there is driveway sign present and a lot of lateral opening. So the three important things for diagnosis: stress X-rays, MRI, and arthroscopy. So what are the reconstruction techniques? The various reconstruction techniques are the anatomical Laprades technique, in which all the three ligaments, the fibular collateral, the popliteofibular, and the popliteus are reconstructed, or the modified Larson, which can be done if there are external rotation and varus instability is of moderate amount. So Laprade is the most anatomical technique in which all the three ligaments are reconstructed. For the Laprade, 2 grafts are taken. There are 4 tunnels, and as I said, all the 3 ligaments are anatomically reconstructed. So this is, I will demonstrate our technique of posterolateral corner reconstruction. So this is the preoperative examination of the patient. You can see this patient had a PCL injury as well as PLC. Opening of the lateral side is significant. These are the landmarks on the lateral side: the head of the fibula, the lateral epicondyle, and the Gerdy's tubercle. Then we draw a line and hockey stick incision based on the lateral epicondyle. So the incision is centered over the lateral epicondyle. A posterior based flap is elevated so that you don't have to do much retraction. And the first step is the isolation of the common peroneal nerve. This can usually be felt either about 5 to 6 centimeter above the fibular head or 2 centimeter below the fibular head. We identify the various planes, the tensor fascial lata and the biceps femoris, and at the back of the biceps we isolate this common peroneal nerve. It is dissected and retracted out of harm's way. Next, we make a tunnel for the fibular tunnel. This is important, is this tunnel has to be drilled from anterolateral to posteromedial direction. It is reamed depending upon the diameter of the graft. The reaming is being done, and then a ethibond or a fiber wire is passed with an anterior based loop. So fibular tunnel is made, and then a fiber wire or a ethibond loop based anteriorly, and these are tied. Next, we identify the back of the tibia for the popliteus tunnel. It is between the Gerdy's tubercle and the tibial tuberosity. This tunnel is made, and again then ethibond is, or a fiber wire is passed through this, and there is a posterior based loop. Next, we dissect over the lateral epicondyle to drill the fibular collateral ligament tunnel. Again, important is the landmark is that there has to be an 18.2 millimeter distance between the femoral tunnel for the fibular collateral and the popliteus tunnel. So we ream these tunnels and then pass the graft through both of these tunnels. Once these grafts are passed through the two tunnels, the FCL and the popliteus graft, then a bioscrew is used to fix these graft in the respective tunnels. In both these tunnels, the bioscrew is passed for an interference fixation. Next, under the fascia, we retrieve the graft of the fibular collateral ligament, and this is passed through the fibular tunnel from anterior to posterior. That is why the loop was placed anteriorly. This is passed from anterior to posterior through the fibular tunnel. And next, we again under the fascia we retrieve the other graft at the back of the tibia, and now both these grafts are then passed in the ethibond loop of the tibial tunnel, and these grafts are retrieved from posterior to anterior. Sufficient traction is put on the grafts to remove any laxity, and at about 45-50 degrees of flexion, and with we do cycling to take away any slack, and at about 45-50 degrees of flexion and neutral rotation, and with varus force, a bioscrew is inserted. So after this fixation, as we can see arthroscopically, the driveway sign has gone, and the PLC has, all the three components have been reconstructed. In summary, in order to improve the outcomes in PLC reconstruction, one must understand the anatomy. We have to understand that all the three static ligaments, fibular collateral, popliteus and the PFL, they are important static stabilizers and need to be reconstructed. X-rays must be done to confirm the preoperative diagnosis. The reconstruction must be anatomical, and today PLC reconstruction is no longer considered to be the dark side of the knee. Thank you very much.